Good morning everyone. Today I'll be talking about drugs that's used for coagulation. Since this is an online lecture, I hope you can bear with any pauses that I would make in the middle of the lecture. Alright, let's get started. As you can see the comic in the slide, when we talk about coagulation, it mainly involves platelet and blood. Before discussing drugs that's used for coagulation, first let's understand the hemostasis process. When there is a vascular injury, the body responds to stop blood loss from the damaged area. For this to occur, 4 steps are involved. Firstly, the vessel will vasoconstrict to reduce blood flow. Then the platelets will gather and aggregate to form a platelet plug. This is followed by the coagulation phase where fibrin blood are formed and clots the blood. The final step will be fibrinolysis to break down the fibrin blood. Clots that stick to the wall are known as thrombus, so they are the unwanted clots. There are 2 types of thrombus. One is arterial thrombus. Arterial thrombus are thrombus that sticks at the arterial wall and is rich in platelet and fibrin, so they are whitish in color and is often associated with atherosclerosis, myocardial infarction, stroke and ischemia, while the venous thrombus develop in areas where there is stagnant blood flow. So very common you see this in deep vein thrombosis. For venous thrombus, they are rich in red blood cells and fibrin and less platelets, so they appear reddish in color and is often associated with chronic heart failure. Thrombuses that dislodge from the artery and veins and floats in the blood is termed as embolus. Both thrombus and emboli are dangerous as they occlude the blood vessels and deprive tissues of oxygen and nutrients. Okay, so this diagram here illustrates the arterial thrombosis and also venous thrombosis. So in the arterial thrombosis, there are more platelet and also macrophages that accumulates together, while in the venous thrombosis, you see more red blood cells. Venous emboli can block the arteries in the lung and pulmonary circulation, so that's known as the pulmonary embolism. So thrombus that leaves the heart or carotid artery and moves and goes to the brain and other organs that and sticks there, it can lead to stroke, death, and other thromboembolic events. So this slide here is just to summarize the formation of thrombus when there's a rupture of the plug, which kind of leads to bleedings and accumulation of the factors. So where platelet aggregation starts taking place and the intrinsic and extrinsic pathways of the coagulations also get activated, and both of these plays a role to form the thrombus. So to treat thrombosis or thromboembolism, we use antithrombotic drugs, and 3 types of antithrombotic drugs that are used are antiplatelets, anticoagulants, and fibrinolytic. So drugs that we'll discuss in the lecture for antiplatelets are aspirin, ticlopidine, Emac. Anticoagulants, heparin, low molecular weight heparin, warfarin, dabigatran, and for fibrinolytics, streptokinase, and alteplase. There are also several other drugs names that is not mentioned in the lecture but may be available in the textbooks, so do please look up on those names as well. Okay, the first class that we'll look at will be the antiplatelet drugs. So what are antiplatelet drugs? They are drugs that interfere with platelet function and is used in prophylaxis of thromboembolic disorder. Okay, so here we have 3 classes of drug that is used as an antiplatelet drug based on their mechanism of action. Aspirin is under the COX inhibitor. Ticlopidine and clopidogrel is under the adenosine PY12 receptor inhibitors, and Emac is under the glycoprotein 3A receptor antagonist. Okay, first we'll look at aspirin. So before we see how aspirin works, we have to understand what does it act on. So our membrane or cell membranes are made of phospholipids, and when phospholipase A acts on it, it forms arachidonic acid, which is like the precursor which COX inhibitor or cyclooxygenase will act on to form prostaglandins and thromboxane. And thromboxane is important for platelet aggregation. Factors like thrombin, collagen, ADP can stimulate the platelet and activates the phospholipase A to form more thromboxane and stimulate platelet aggregation. So what does aspirin do to this? So aspirin will irreversibly inhibit the COX enzyme. So when you inhibit COX, you have less production of thromboxane and less platelet aggregation. So aspirin is usually given in low doses to selectively or relatively selective to inhibit the thromboxane in the platelet. So aspirin is actually an NSAID, so it is used in high doses to treat inflammatory conditions like rheumatoid arthritis and joint pains. In moderate doses as an analgesic, and in low doses as an antiplatelet agent. So the effect lasts 7 to 10 days until new platelets are formed because it binds irreversibly, and it is used for long-term thromboprophylaxis in people with high myocardial risk like myocardial infarction. Well, if you had lectures on NSAID, you will know aspirin has a lot of adverse effects. So for simplifying, so if you look at this, aspirin, the adverse effects is like asthma. So asthma-like symptoms that is induced by aspirin. Saline, which is like ringing sound in the ear, is called tinnitus. You have nausea and vomiting, that's saline. One of the main adverse effects of aspirin is peptic ulceration or internal bleeding, so which is very common for all the NSAIDs, and Reye syndrome in children who has viral infections, and there are several other idiopathic effects like respiratory alkalosis and so on, and noise, which is tinnitus. Okay, the second class of drug that we'll look at which is ticlopidine and clopidogrel. These are drugs that inhibits the ADP binding to its receptor, which is P2Y12 receptor on the platelet irreversibly. So as you can see, so ADP, when it binds to the receptor, it will stimulate calcium influx that will activate the GP2B3A receptors. So if you prevent the binding, you prevent the activation of the GB receptors. Okay. So these drugs can be given orally, and clopidogrel is a prodrug that must be metabolized by the CYP enzyme, so in the liver, before it actually can produce an effect. So peak effect is about 5 to 7 days because it also binds irreversibly, and it has an additive effect with aspirin, and it's used to treat or prevent myocardial infarction or stroke or peripheral arterial diseases. It's used as a prophylactic for thrombotic events in acute coronary syndromes and prevent thrombotic events associated with percutaneous coronary intervention with or without coronary stenting. So again, like aspirin, bleeding is the most common adverse effect, but specifically like ticlopidin, it has also additional adverse effect like severe hematological reactions like neutropenia and thrombocytopenia. Okay, the third class of drug that we'll look at is Emac. Okay, Emac is a monoclonal antibody, and how it works is it inhibits the GP2B3A receptor. So once this receptor is blocked, you will prevent the ligand of the receptors from binding to it. So the ligands are fibrinogen and von Willebrand factors. So when the ligand cannot go and bind to the receptor, there won't be any platelet aggregation. So this is a monoclonal antibody, so it's given intravenously for a short-term treatment, and it is used along with heparin, which is an anticoagulant, and aspirin as an adjunct for PCI and also for the prevention of cardiac ischemic complication. Again, the adverse effect for all the antiplatelets is bleeding if you use it together with anticoagulant. Okay. This is sort of a summary to just show where does the different classes of the drugs that works on platelet aggregation. So you can see aspirin works at the upper stage where formation of thromboxane, which is needed for platelet aggregation. Okay, and then you have ticlopidin and clopidogrel that prevents the ADP receptor ADP from binding to its receptor, and then you have the GP2B3A receptor antagonist that blocks preventing the ligands from binding to the its receptor. Okay. We also have several others and other drugs names which you can also look up on the textbooks. Okay, the next class that we'll look is on anticoagulants. So anticoagulants are drugs that prevent the development and enlargement of the clot. Just now, antiplatelets prevent the formation of platelet aggregation, while here anticoagulant is prevent the platelet that's already formed, okay, aggregated already, so to prevent further development or enlargement of the clot. So under this, we have heparin and low molecular weight heparin. We have oral anticoagulant. We have thrombin inhibitors, and there are other classes. So warfarin is under an oral anticoagulant. Dabigatran is a thrombin inhibitor. There are also several other thrombin inhibitors that you can look up. And there are another class also like fondaparinone. Okay, before we talk about anticoagulant agents, let's just look briefly on the coagulation cascade. So coagulation cascade, we have the intrinsic pathway, okay, and also the extrinsic pathway. So the intrinsic pathway, where the factor 12, okay, converts to 12A, then to factor 11 to 11A, factor 9 to factor 9A, and then we have factor 8. Okay, we have factor 7 for the extrinsic factor, but all this, the common pathway for all this is the factor 10. Okay, that leads to the formation of thrombin from that is the important mediator that forms the fibrinogen to form fibrin clot, which is factor 13. Okay, the first class of anticoagulant I will talk on is on regular or unfractionated heparin and low molecular weight heparin, which are heparin fragments. Enoxaparin and dalteparin belongs to the low molecular weight heparin. Both heparin and low molecular weight heparin acts by activating antithrombin 3. Just now we saw the coagulation cascade. Thrombin is needed to convert fibrinogen to fibrins. So if you block the thrombin by activating antithrombin, it will inactivate the clotting factor. So this is illustrated by the diagram here. So unfractionated heparin, when it binds to the antithrombin, it will accelerate the interaction with factor 10A and thrombin, while the low molecular weight heparin, when it binds to the antithrombin, it will accelerate the interaction of an antithrombin with factor 10A. Similarly, just now we mentioned about another drug, that fondapaxillam. It also acts similarly like the low molecular weight heparin by inhibiting only factor 10A. Okay, the table here summarizes the differences and similarities between the regular or unfractionated heparin and low molecular weight heparin. So heparin can be given by intravenous route and subcutaneous route. The low molecular weight is given by subcutaneous route. The low molecular weight has a longer half-life compared to the heparin, and it is eliminated by the renal excretion. Both heparin and low molecular weight heparin doesn't cross the blood-brain barrier or the placenta. So there is a monitoring that is involved when someone is given heparin. So they have to be monitored for the activated partial thromboplastin time, or APPT time. And this is more common for heparin than the low molecular weight heparin. Both of these drugs are always grouped together because they're used for the treatment of acute venous thromboembolism, like deep vein thrombosis or pulmonary embolism, and it is used against prophylaxis against venous and arterial thrombosis. So heparin and low molecular weight heparin, if you give too much anticoagulant, you also have a risk of bleeding. So there's an antidote for overdose of heparin or low molecular weight heparin, but more common with heparin, you have an antidote which is protamine sulfate. Okay, so these are three major adverse effects of heparin. Major one is the bleeding. Then you have hypersensitivity and thrombocytopenia. So in the cases of bleeding, either you stop giving heparin or you give protamine sulfate as an antidote when there is an overdose of heparin. Other adverse effects are like osteoporosis. This is if it's used long term, and hypoaldosteronism with consequent hypercalcemia. The next class is warfarin, and warfarin acts by inhibiting the vitamin K, so it's known as a vitamin K antagonist. But if you specifically want to explain the mechanism of action, is it inhibits competitively the vitamin K epoxidase reductase component, so it prevents the reduction of vitamin K epoxidase to its reduced form. So this basically antagonizes vitamin K. Okay. So the synthesis of the clotting factor will diminish within a few hours, and different clotting factors will slow down at different times. Okay, when you give warfarin. The anticoagulation action of warfarin only starts 1 to 3 days later. Okay, between 1 to 3 days, because the different factors will stop synthesis at a different time. So warfarin is a small lipid soluble molecule, so it's readily absorbed and is highly protein bound and have a half-life about 36 hours and metabolized in the liver and readily crosses placenta. The dosing is variable. Warfarin also requires monitoring, and it has to be individualized, and usually people who are on warfarin, prothrombin time or international normalized unit INR is monitored to ensure that they don't get an warfarin overdose. So if INR ratio, optimal ratio is 1 to 3. So anything more than 3 or below 1, then they have to adjust the dose. So what is warfarin used for? Warfarin, again, similarly, is used for venous thrombosis, pulmonary embolism, and also can prevent thromboembolic stroke. So these are all prophylactic agents. Adverse effects of warfarin is bleeding, especially in the bowel and brain. Okay, so if there's minor bleeding, because it's a vitamin K antagonist, you can give vitamin K. But if you have a life-threatening level of bleeding, then you give fresh blood transfusion along or blood factors to activate the clotting. Another adverse effect is teratogenic, so it should never be used during pregnancy. But if pregnant women do require anticoagulant, so usually heparin or low molecular weight heparin is administered because they cannot penetrate the placenta. And another adverse effect is skin necrosis. It's very rare but can be serious. It can be reduced by giving heparin and warfarin concomitantly. The important thing about warfarin is that warfarin has a lot of drug-drug interaction. So there are factors that can inhibit the warfarin metabolism, so it potentiates the anticoagulation action, or there are factors that can stimulate the warfarin metabolism and attenuate the anticoagulation action. Okay, so examples of those that can potentiate the anticoagulation effect of warfarin, if you give aspirin together with warfarin, so you're giving an anticoagulant and antiplatelet together, so you have a higher risk of bleeding. If you have hepatic diseases, then it cannot be metabolized, then you have anticoagulant effect is too much, then you have a risk of bleeding. While the drugs like barbiturates, ripamycin, which are inhibitors of the stimulators of the cytochrome enzymes, can activate the stimulate the warfarin metabolism, so the warfarin won't be as effective as it should be. So again, it is a vitamin K inhibitor, so if you give vitamin K together with warfarin, so they will compete, and that will reduce the effectiveness of warfarin. So the third drug that we'll talk about is dabigatran. So dabigatran is a direct thrombin inhibitor. So we mentioned that thrombin is like the middle ground that requires to convert fibrinogen to fibrin. So if you inhibit thrombin, then you don't have the formation of fibrin. So it's also given orally, and it is clinically used to prevent venous thromboembolism, usually following knee or hip surgery, and also for prevention of stroke, systemic embolism in atrial fibrillation. Again, it's an anticoagulant. The adverse effect is bleeding. So what is the advantage of dabigatran over warfarin is that it has an immediate effect. Now warfarin, it does take time before you can see an effect. As a predictable dose-response relationship, less drug-drug interaction, and does not require monitoring of INR like for warfarin. You have to monitor and adjust the dose accordingly. Okay, so this slide just sort of summarizes where does warfarin, heparin, and dabigatran act on. So as I mentioned, factor 10 is the common pathway between the intrinsic and extrinsic factors. Warfarin, because it can block different factors, so it can block factor 10, it can block factor 9, it can block prothrombin too. So it does take it takes time before you see the effect of warfarin. Dabigatran is a direct thrombin inhibitor, so it directly inhibits the thrombin thrombin effect, while heparin, it will activate the antithrombin to go and block the thrombin as well as the factor 10A. So this is how the drugs act. Okay, the next class we will talk is fibrinolytics. So these are drugs that is used to lyse the already formed drug. So first we try to use the drug that prevents the aggregation. Second is if it's already formed, we try to prevent it from becoming bigger or dislodging from the vessel. So third is you want to make sure that they don't block the arteries too much. You try to lyse the already formed clot. So this is where fibrinolytic plays a role. So they will fibrinolysis is the process that breaks down fibrin that holds the clot together. So it is initiated by the activation of plasminogen to plasmin. So as you can see in the diagram here. So where does fibrinolytic act? They will act by activating the plasminogen activator. So examples of drugs that's classified under fibrinolytic is streptokinase, ureakinase, and alteplase. Alteplase is a tissue plasminogen activator. Streptokinase is a first generation fibrinolytic. So the problem with streptokinase is it forms a systemic fibrinolytic state, so you end up having a bleeding problem. So the second generation was came up, which is alteplase. So it acts more locally on the thrombotic fibrin. So it's a clot selective to produce fibrinolysis. So it try to reduce the systemic a bleeding problem. So these drugs have to be administered intravenously, and they do have beneficial effect if you give it together with an anticoagulant. Again, adverse effect, there is still the risk of bleeding, like GI hemorrhage or hemorrhagic stroke, possibility of hypersensitivity, especially with streptokinase, and hypotension. This diagram here shows some differences between streptokinase and alteplase in sense of antigenicity. Okay, so a high titer antibodies develop between 1 to 2 weeks after use. So streptokinase cannot be used too long. Okay, alteplase is more specific. Fibrin specific, so it's clot, or we call it as a clot specific compared to streptokinase. Half-life, although it is more clot specific, half-life is shorter than streptokinase. So fibrinolytics are used for in patients with acute myocardial infarction, together with aspirin and heparin co-administrated to prevent the reocclusion. It is also used in the treatment of deep vein thrombosis, especially when you have in the leg, pelvis, or shoulder. It also can be used for pulmonary embolism and selected stroke patients. So all the antiplatelet, anticoagulant, and fibrinolytic, one of the main adverse effects that if you notice is that all of this can cause bleeding. So how do you treat when there is bleeding for these conditions? So if there is bleeding that is caused by fibrinolytic agents, okay, so you can give tranexamic acid. Heparin, the antidote for heparin overdose or bleeding due to heparin is protamine sulfate, and for warfarin is a vitamin K antagonist. So if you have bleeding, you can give vitamin K1. And here on the other side, you can see the monitoring parameters that is usually, and for warfarin, you have to monitor the prothrombin time and the INR, while for the heparin, you have to monitor the APTT if required. Okay, this slide shows the connections between the antiplatelet agent, anticoagulants, and also the fibrinolytic agents, so to give you an overall picture on when there is an atherosclerotic plaque or a thrombus formation within the blood vessel wall. Right, so that's the end of the lecture. So here are the reference books that you can refer to for the lectures. And as I said, if you have any questions, feel free to email me at my email, which is found on the first slide. So thank you.